Well, hello, everyone. Thanks for the very generous introduction. I'll be speaking about psychedelics, ethics, and love. And I'll just sort of dive right in. For the longest time, at least when I was growing up, if anybody mentioned psychedelics, a certain kind of picture would come to mind. It'd be something like this. Psychedelics were overwhelmingly associated with a certain counterculture. In my case, I grew up in the United States, so, the US hippie movement. And nowadays, if you hear psychedelics, you might have a different type of image come to mind, something that's a little bit more medicalized. It looks a little more mainstream or standardized in some sort of a way. Just for fun, does anyone happen to know who this is in this picture? Yeah, Anderson Cooper. So this is a very popular television host in the United States who's here undergoing a form of psilocybin-assisted therapy and having this experience on a national television program. So when I was growing up, a very mainstream person like Anderson Cooper would not have been caught dead in such a situation, and yet here it's sort of being presented to the public as the next great thing in medicine. So what's going on behind this shift in attitudes? One thing I think is that psychedelics are being rebranded in some sense as medicine, and medicine is supposed to be good for you. And so in order to think that psychedelics could be something that it is quote unquote legitimate to use, a big push has been to try to treat them as medicine. Now, of course, a drug is just a drug. So if we call it medicine, that is going to inspire certain types of thoughts and regulations and legal responses. If we call a drug, if we just call the same substance recreational, very different types of connotations come to mind. And maybe we have different attitudes and we assume it's going to have different effects. And so how we frame or think about what a given substance is, depending on how it's used, the context and so forth, can have pretty significant downstream consequences. So today I'm going to talk about the use of psychedelics and other non-psychedelic psychotropics like MDMA or ecstasy as potential adjuncts to couples therapy. And some of these ideas were co-developed with this person here. This is Julian Savulescu, who has been the Uhiro Chair for Practical Ethics at the University of Oxford. And this is our co-authored book called Love Drugs in the US and Love is the Drug in the UK, for reasons to do with branding preferences by different presses. So it's the same content. This is not two books. I wish I'd written two books in this period of time, but this is one book with two covers. So just a quick declaration. I'm directing something at Oxford called the Hub at Oxford for Psychedelic Ethics, which spells out HOPE, which we thought was pretty clever. And I'm co-directing it with Dr. David Yaden, who's a professor of psychedelic research at Johns Hopkins, which is where a lot of these medicalized trials have been going on, looking to see if psilocybin from magic mushrooms as an adjunct to psychotherapy can be helpful for treating a range of mental disorders. So we have received a small anonymous donation to help with travel scholarships for people who otherwise wouldn't be able to come to a workshop, but just to be explicit about it, neither David nor I are paid in any way for our involvement with this hub. Okay, so I'm just going to give an overview of what I basically hope to cover in the next 45 minutes, and then you'll have the big picture, and then we'll see how much of the details we can get into for purposes of elaboration. But here's the big idea. Now that psychedelics are being rebranded and reintroduced as medicine, they're following the standard Western model of medicine, which is that it's very individualistic and it's focused on particular patients who come in and their symptoms, and the idea is to treat those symptoms of a disease or a disorder. And so key examples would include post-traumatic stress disorder or treatment-resistant depression. These are the kinds of things that they're trying to treat these days. But post-traumatic stress disorder, just to linger on that example, isn't just an individual level phenomenon. Anytime any one of us is dealing with certain types of challenges in our mental health and in our relationship to the world, it has implications for the people that we love and care about and the relationships within which we're embedded. So a major point of this whole talk, and certainly what we try to argue in the book, is that if we're going to bring these powerful drugs back into society as a form of medicine, we really need to think ahead, not just about how can we see them as treatments for specific individual level symptoms, but what are the implications of these drugs for our relationships and for our communities and for society more broadly. So to illustrate this point, I'm just going to give you an example that has nothing to do with psychedelics initially. I'm going to talk about SSRIs. So SSRIs is a class of drug. It stands for selective serotonin reuptake inhibitor that's very commonly prescribed for depression and anxiety and some other conditions. And in fact, it's so commonly used for this that in everyday language, we tend to just refer to these drugs as antidepressant pills. So we call them by what we use them for. But in reality, they're just selective serotonin reuptake inhibitors. That's exactly what they do. The name is on the tin. And so what is the implication of selectively blocking the reuptake of serotonin? Well, all sorts of things follow from that. One of them, if you measure it, is that it blunts certain feelings of depression in some people, although there's debates about exactly how effective it is compared to placebo. Another thing it does is it lowers libido in a fairly large proportion of people who use it. Now, we don't call them libido-depressing pills. Why not? Just because that's not what we hope it won't do that. But it does do that. So we could just as well call them libido-depressing pills. Another effect that SSRIs have on some people is that in addition to blocking their own feelings, it can make it hard for them to care about the feelings of other people. So, if I'm in a close, loving relationship and my partner comes home and is really distressed about something at work, and I just don't feel moved by that distress, I just sort of can cognitively understand that distress is happening, but I don't feel compassion. I don't feel intuitively motivated to comfort them. Well, that's not just a me issue. That's something that has pretty significant ramifications for the relationship that I'm in. But when your doctor prescribes selective serotonin reuptake inhibitors, they don't often mention on the side effects like may prevent you from caring about your partner's feelings. That's not the sort of thing that tends to get listed as one of the effects of these drugs, but it's an effect of the drugs for some people. So science can only see what it measures. And what we're proposing here is that whenever you introduce a drug into somebody's neurobiology, you should try to measure the full range of effects that it's having on them and their relationships. You shouldn't only measure the effects that you intend to see or the side effects that you anticipate might occur. So happily, there's a little bit of a sense that some of this new research might be taking a relational turn. So I'll cover for you some initial studies that do in fact look at the interpersonal effects of psychedelic-assisted therapies. The particular one I'll look at is actually an MDMA-assisted treatment for post-traumatic stress disorder, where the partner of the person is included in the therapy. So that's what we'll look at a little bit later on. Now, as soon as you introduce more than one person to a clinical encounter, ethical problems sort of multiply. One issue is that you may have power dynamics within a couple that are different from the power dynamics that only exist between a patient and a doctor, let's say. So, if one partner is exerting coercive control over the other member of the partnership and is sort of dragging them into this experience and wants to maintain the relationship when maybe the other person has good reason to want the relationship to end, that's now much more complicated than just trying to elicit the informed consent of the person in front of you. So I think we should be looking at relationships, but we should do it with our eyes wide open. We should be aware that that's going to make things complicated. But I don't think complexity is a reason not to do it. It's just a reason to get ahead of the conversation and try to figure out exactly what the ethical implications are and how to manage some of the potential risks. And as I'll discuss briefly about halfway through, there's also maybe a deeper problem with consent. And that is that some people think psychedelics can have what they call a transformative experience. It can induce a transformative experience. And a transformative experience is a technical term from philosophy. We also use it in our everyday life. But in philosophy, what it means is it's an experience that in some ways sort of changes who you are. It might, for example, change your whole value structure or what you take to be important in your life. And so if you're one sort of person at time one, and then you undergo this transformative experience and you have rather different values at time two, it's unclear how you can rationally decide whether to undergo the experience, because on the other side of it, you'll almost be another person who values things differently. And so some people think there's actually a deep logical problem here for getting informed consent for psychedelic-assisted treatments, because they have this potential to induce a transformative experience. And again, just how much more complicated does that get when you have a couple who's now thinking whether they may want to jointly undergo what might be a transformative experience for their relationship, or maybe even for their love. You might think, will we be the same couple at the end of this experience? These are the sorts of questions that I think we should be asking. A final issue that I'll dig into with some detail is that there's a major risk when we start bringing relationships into the realm of medicine that we end up thinking of relationships in terms of medical categories. So instead of thinking, well, a couple is just dealing with ordinary relationship problems and maybe they want to get some help for those problems, we might need to start thinking, oh, well, maybe they have a relationship disorder and they have to get a treatment for their relationship disorder, because that's how we make drugs available in society. We either treat them as illegal recreational drugs that we either, or that we tolerate in the case of alcohol and nicotine, or that we don't tolerate in the case of other drugs, or we call them medicine. And those are the only categories that we have for drugs. So if we want to give people drugs that we think may help them, we have to think of it as medicine. But if we think of something as medicine, we have to think of what they're experiencing as something that's a disorder so that we can treat it, because that's the logic of how we prescribe or make drugs available under the current paradigm. Okay, that's basically what I want to cover. Now I'm just going to put some flesh on these ideas. Let's go back to the example of PTSD, and just to illustrate how this can have interpersonal effects. It should be intuitive, it should be obvious. Anybody who either has PTSD or knows someone in their life will find this very clear. But here's an illustration of it. PTSD not only affects one's own mental health, but can negatively affect one's marriage, is what they're looking at in this study, but any long-term close relationship and family relationships, other types of loving relationships can also be affected. In the context of a marriage, they say the symptoms of PTSD can create problems with trust, closeness, intimacy, communication, decision-making, problem-solving, and can even give rise to the destruction of relationships. The partner can feel a lack of connection and feel like they're being pushed away. So one immediate implication of this is that if you can successfully treat PTSD, it will probably have good implications for a relationship, because for the most part, PTSD stands as an obstacle to a healthy, loving relationship. So if you can somehow remove or resolve the underlying trauma, or you deal with the symptoms in some way, for many people, on balance, this is going to lead to an improvement not just in their own mental health, but in their relationships as well. So already we can see that just ordinary treatment approaches, if they work, can have interpersonal implications. But the question of whether drug-assisted therapy is effective for PTSD in individuals, it's still being studied, but it looks promising that at least for some individuals, it could be very effective, more effective than some other treatments. But it's unclear whether you have to actually have PTSD to benefit from a drug-assisted therapy. So again, take the example of couples therapy. Just set drugs aside. Imagine you and your partner dealing with relationship difficulties, and you're not necessarily, neither of you has a diagnosable condition, let's assume, but you just want to try to improve your relationship. You want to have a better relationship. So what do? You might go see a counselor or a therapist of some kind. Now, by doing that, you're not thereby confessing to having a disorder, you're just trying to make your life better. But what if we want to add a drug to that we think has a chance of increasing the effectiveness of the therapy? Now again, we haven't studied this carefully. We're just going on anecdotes and a few pilot studies. But let's just imagine that some psychedelic substances, or MDMA, if used in the right way as an adjunct to couples counseling, could make the counseling more effective at helping the couple work through their problems. Well, here you're going to have a problem, because under current norms, making a drug available for a couple who just wants to improve their relationship isn't seen as a legitimate use of a drug. Drugs are supposed to be medicine, and medicine is supposed to treat something. So you see there's this tension here that we're going to keep coming back to. And just as a broader point, what we characterize as a mental disorder often has to do with meeting certain diagnostic criteria. And the specific diagnostic criteria are established by committees of people with some level of expertise who make a determination about what they think is a serious enough problem to warrant a diagnosis. And sometimes that's an arbitrary line that's drawn. Maybe you meet 4 out of the 5 symptoms. It doesn't mean you're not suffering, but maybe you don't get the diagnosis. So, whether we think something it could be improved doesn't come down to just whether someone happens to meet the diagnostic criteria. And so we need to think about that as well. And it's all well and good to make the point I'm making, which is that it is possible that people, apart from those suffering from diagnosable mental health conditions, could stand to benefit in some way from drug-assisted couples therapy. It would be worth finding that out. But when you actually imagine trying to run a trial to do this, you can't just tell the regulators and the ethics review board that you just want to see whether it helps couples improve their relationship. You're going to have well-defined criteria, You're going to have measurable outcomes that you can show improvement on. And those measurable outcomes will probably have to do with symptoms of a problem that's been well studied in a scientific sort of a way. So if we want to get proper evidence of whether this can be helpful for people, we may have to adhere to some of these pathologizing tendencies. Now, so far, there's some research that tries to take a compromise approach. Basically, one person has PTSD, and then their partner is invited to join them in the MDMA-assisted therapy. So this way, they're taking advantage of the fact that there's a diagnosable condition here, but what they're really interested in is, does this help the relationship? So this is sort of where we are today, and this trial has just come out in the last couple of years. Now, it's very preliminary. It's a pilot study with a very small sample. There's 6 couples. One of the partners has PTSD. They underwent 2 MDMA-assisted sessions over 7 weeks, interspersed with cognitive behavioral therapy. There's no control group. It's what's called an open label trial, so people know very well that they're getting the drug. There's not a placebo. So it's unclear if there is an effect that it can be attributed to somehow the drug itself as opposed to other things like the CBT, for example. But let's just see what the study found. So clinically significant improvements were observed on all of these kind of medical criteria, including PTSD symptoms. But what I want to draw your attention to is that there were also improvements in relationship adjustment and happiness. So relational happiness is one of the outcome measures in this study, and there's a particular scale that they use to measure this. So it's actually not that far-fetched to think that you could come up with measures that assess something like interpersonal well-being. Now, it might not be that exact language that's used in these measures, but here is an example of scientists trying to operationalize the notion of interpersonal flourishing. So that's the status quo. We have some preliminary evidence, and maybe there's a there. But there's some historical examples as well, which I want to share with you now. So before MDMA was prohibited, before it was listed as a Schedule I substance in the United States, it was used in therapeutic contexts, experimentally. And these researchers wrote a retrospective article of their experience working with about 80 clients in the early 1980s, before MDMA was illegal. And this, again, is not a controlled study. These are basically clinical anecdotes and notes and case studies that they've cobbled together. But here's what they have summarized about their experience. They think that MDMA, administered in the right way, with the careful oversight of a trained professional, can help individuals achieve a more healthy and accurate perspective of who and what they are by decreasing irrational fear responses to perceived emotional threats. Now, I want to unpack this because there's actually a lot in there. One thing is that in the popular discourse, many people seem to think of certain drugs like MDMA, and maybe particularly psychedelic drugs like psilocybin from magic mushrooms or LSD, as things that cause you to hallucinate, to basically see things that are not real. So the common stereotype about drugs is that they distort your perception of reality. But here these authors are claiming that the use of this powerful drug can actually help people better see what's true about themselves and their own emotion and perhaps their relationship to their partner. So they provide a mechanism here. They say, well, it's due to decreasing irrational fear responses to perceived emotional threats. Now, it's true that MDMA directly suppresses reflexive fear responses by working on emotional centers of the brain. That is what it does. And this is one of the reasons why people think it may be helpful for PTSD, because PTSD involves having an overreactive fear response. And that's part of the problem. But some of our fear responses are not irrational. You know, imagine you're in a relationship with somebody who harms you, and you feel frightened when you think of them. Now, if you take MDMA, it might suppress the fear response, but maybe it's suppressing the rational ones too, not just the irrational ones. So this is why it's going to be really important to figure out not just what does the drug do, but how does it work, and which are the couples who might stand to benefit from MDMA-assisted therapy versus which are the ones where it might put at least one member of the couple at risk by causing them to feel more trusting or open toward a partner that they should be more wary of. So that's going to be an important issue. Another thing here is just to talk about the phenomenology. So when people are on MDMA, you can be thinking about a party scene, or you can be talking about an MDMA-assisted clinical environment. You're going to have some similar subjective feelings, one of which is the sense of love and acceptance of oneself and others. Now again, this can be helpful for a therapeutic context, but I think you might wonder whether that feeling of love that you have is really authentic, or whether it is just a temporary drug effect that you shouldn't hang too much on. So, many people know the experience of meeting somebody under the influence of MDMA and thinking that they're really special and that they're gonna, have this wonderful relationship together, and then the effects of the drug wears off, and maybe they really get to know each other better, and it turns out that they don't have shared values, and actually they're quite irritating and so forth. So, it's common knowledge that the drug can be distorting. It can make you seem to like someone who, in your sober state of mind, you don't really think is all that great. But it can, under certain circumstances, help you have a better appreciation of someone. For example, if your irrational fear responses are preventing you from seeing them as they are, or seeing your own emotional life as it really is. So it really comes down to the details, whether this is something that promotes an accurate perception versus something that distorts your perception. So these are some of the things that people reported. They feel more loving toward their partners. They could more easily forgive the pain of the past. They could let go of grudges and misunderstandings. And the point I want to make here is that none of these are really medical problems. Being able to forgive someone is just part of being a human. It's not, maybe if someone really struggles to forgive someone, you could imagine someone trying to pathologize that and saying you have forgiveness disorder or something like that. But the point I want to make is that there's lots of things we can do to try to have a better and I was about to say more healthy relationship, but there you can see I'm using the language of health just in trying to make my point. Where we might want to resist thinking of them in terms of pathological categories. So in this book, partly what we argue for is that there are ethical reasons to try to make available certain experiences if we reasonably expect that they will help people's lives go better, whether or not they have a disease. So the argument is, if it turns out that drug-assisted couples therapy could genuinely help some couples have better relationships, and better relationships are intrinsically valuable, and they also have all sorts of good effects on our lives, then there's a reason to make drug-assisted couples counseling available. And that we shouldn't have to first pathologize the couple to justify why we're making it available. So we argue for something called an enhancement framework, where we suggest that the point is to increase well-being. One way you can increase well-being is by treating the symptoms of a disease. But another way you can increase well-being is by helping people work through their problems, whether or not they have a disease. And so this is sort of the ethical argument that we ask people to consider in this book. But again, to come back to a point I made earlier, translating that into getting permission to run a study in a clinical context may not be straightforward. And so earlier today I was talking with some folks in the psychiatry department, and this is where I think a conversation needs to happen. How do you translate these ethical ideals to actually getting permission to run a study, to collect the kind of evidence that's required to see who stands to benefit and see who would be harmed? Okay, so now I want to step back a little bit and just think more broadly about the concern I raised about bringing relationships into the realm of medicine at all. Now, there's two ways of thinking through ethics. One is to come up with specific case studies where you kind of describe the case in terms of very specific details, almost like you're doing a trolley problem of the heart or something like that. Imagine that this specific thing is happening and compare it with this specific other thing, and it can help you get clear about what's at stake in a given context. But sometimes when ethicists are dealing with these minute examples that are very carefully constructed and often a little bit artificial, they can miss the bigger picture about the wider implications. And so I want to take a little bit of time to talk about and to acknowledge that there are wider implications here. Even proposing to bring relationships or love into a medical context is something that we might want to be wary of, even if some couples would stand to benefit from this. So here's the worry. It's been expressed by various people, but I thought this particular quote was really powerful. Many people have reached the normative conclusion that they do not want to live in a world where increasing swaths of human experience are under the logic of medicine. There are or should be experiences that use an older logic, which are under the jurisdiction of another profession or under no jurisdiction at all. We can all fear the medicalization of love. So that's by the sociologist Jonathan Evans. Now, I have to say, this has a very strong intuitive appeal to me. I really, and I've sort of expressed some of that in this talk so far. But I also think it's important to try to break down what exactly is the fear when people raise the fear of medicalization. So one thing I've mentioned is that it often requires that we have to pathologize ordinary life experiences to explain why someone should have access to a drug or another treatment. That's one problem. Another problem is just that it seems to expand the control of medicine as a social institution over our lives. Medicine has been very effective, and it's helped treat diseases that otherwise didn't have treatments. But in part, because of that success, we now start to think that medicine should be the solution to all sorts of problems. You know, you need a drug for this or a pill for that, or what does your doctor say, instead of thinking, you know, maybe what you need is more time with your friends, or maybe what you need is to read poetry. There's lots of other ways that you can contribute to a flourishing life, but we tend to collapse everything into, is it healthy or unhealthy? As though those were the only two categories, if that was the only dimension of value that we care about. Another problem with medicalization and with medicine generally is it tends to focus in on individuals. So there's almost a built-in lack of awareness of the structural context within which a person is living their life. Because who comes into the doctor's office? Usually it's one person who then comes in and tells you about their symptoms. You can't actually see their whole life. They can tell you about their family, they can tell you about their job, you might get a rough picture of it, but there's something built into the very structure of a doctor-patient interaction that you're going to focus on a person and their symptoms. And not only that, there tends to be a focus on the biological basis of their symptoms, because medicine feels more confident when it's treating physical symptomology. When we talk about minds and psychology, we start to get a little bit uncomfortable whether our models are adequate. And so we tend to look for a biological explanation of whatever it is that a person might be experiencing. And then finally, in the case of love, I'm just going to kind of end on questions about whether drug-influenced love really is authentic. So go back to the MDMA example. If you feel that you love someone, if you report that you love someone after having had an MDMA enhanced experience, it's a real question whether what you feel is real, or whether you're having a kind of illusion. And so that's what we'll conclude on. Okay, I just want to zoom in on these 2 points. There's this great work in sociology by Peter Conrad where he talks about the medicalization of society. And I just want to pull out this quote. Medicalization, basically, treating something that is not normally understood to be a medical problem as though it is a medical problem, can obscure the social forces that influence well-being. For example, by focusing completely on the neurobiological features of some condition, it might be seen as a genetic or a biological problem, and then it follows from that people think it should be treated predominantly with drugs. Barbara Wooten, in an older book, has a very pithy statement to encapsulate this concern, which is, it's simply easier to put up a clinic than to pull down a slum. Now, this is making a slightly more sophisticated point than Conrad was. It's that when you treat something with medicine, actually, it often sort of works. And when it works, at least to some extent, it actively disincentivizes you from continuing to worry about the problem of how to make structural changes. So it's not just that you're sort of treating a non-medical problem with medicine, it's that even though it might not ultimately be a medical issue, medicine can still be effective for non-medical issues in terms of helping people sort of get by. And if they can get by, then why would the politicians bother with dealing with the underlying economic inequalities or whatever it is that's actually driving people to suffer in the first place? Here's another illustration of the same principle with a story from Jonah Lehrer. He tells the story of a friendly psychiatrist who's very eager to help his patients, and he has a problem, which is that he fails to distinguish between suffering that's rooted in his patients' bodies and suffering that's rooted in their minds or their social context. So he has an encounter with a patient. He says, "How's your medication working out?" And in this story, I believe the medication is an SSRI for depression. And the patient says, "It's working great. I feel so much better. But I'm still married to the same alcoholic son of a bitch. It's just that now he's tolerable." That's a really hard case. And it brings us to the ethics of relationships, which is going to be really important, because you might think, in some cases, the right thing to happen is that the relationship should end. So using drugs and couples therapy and all these other methodologies to try to sustain a relationship sometimes is probably, all things considered, not warranted. So in order to figure out whether it makes sense to even enroll a given couple in a trial, you have to make a prior ethical judgment about whether it's a relationship that's worth sustaining. Now, in this case, you might want to say of this person, we don't know too much about her circumstances, but you might say, well, if you've got an alcoholic son of a bitch, you should just leave him. You want to take antidepressant pills so that you can, suffer through and kind of tolerate him. But it gets more complicated than that because some people don't have the wherewithal to leave a relationship. So then maybe tolerance is the best that they can hope for. So you think maybe we should not make drugs available in these cases because then that will sort of force people to deal with their circumstances? I'm not sure that follows. So at the very least, it's a very difficult case. Now, my colleague Christina Gupta has made the sort of helpful but obvious point that it isn't either or. It isn't either we look at individuals or social systems, or either we look at biology or psychology. Biology and psychology and social circumstances all interact with each other, and interventions along one dimension can have knock-on effects on the other. And so we do have to think holistically in a kind of biopsychosocial way about, given a certain problem, what are all the different levers that we should pull? What are the benefits and risks of pulling those levers? And what are among the prudent ways of proceeding given those benefits and risks? So she points out that individual and structural, biological and social are co-constitutive. Interventions that are aimed at an individual can be effective, and they can have reverberating effects on the broader social issues, and vice versa. Just to illustrate this, imagine that you are really depressed and you can't get out of bed. And maybe you're depressed because you hate your job, but you need your job to pay the rent. So, you got to do something here. Now, you might think, what you don't want to do is just give someone an SSRI so that they can, begrudgingly show up to work and kind of carry on, earning a paycheck and kind of dragging through life. But actually, suppose that this person is among the subset of people for whom SSRIs are an effective treatment of the symptoms of depression. It kind of helps them get out of bed. Even though the ultimate problem we're supposing is, their work life or relationship problems or whatever it is, it might be that being able to get out of bed is the first step that the person needs to take to be able to engage with those wider problems, to maybe have the energy to even look up alternative jobs that they could potentially apply for. So we should always be careful not to say it's either this or it's that. These things can have complex interactive effects. So the idea here is then to think about how do you integrate social with individual and biological with psychological interventions to potentially achieve change. Now, another area of social concern is at the level of laws and regulations. And what we're seeing is, in addition to some of the experimental work in science that I showed you earlier, there's some experimental laws being passed in some jurisdictions. And this happens to be in the state of Oregon, which is a state in the United States. I was born in Washington, so this is just sort of below me on the map. And Oregon has implemented what they call supervised consumption. So they create these little centers where you can go and legally consume psilocybin from mushrooms with a guide sort of watching to make sure that you're okay, without even the pretense that you're having a medical treatment. In fact, they don't require that you give any reason at all why you want to take this drug. Maybe you're exploring your consciousness. Maybe you're sort of self-medicating. Maybe you just think it would be fun. It's really striking to me that a law has been passed in the US in these days where there's this open acknowledgement that maybe drugs are not only recreational or medical. Maybe they don't only have to be illegal and seen as bad or legal and seen as medicine. Maybe there are different uses to which drugs can be put. So this is early days, it's an experiment. I don't know how this will turn out, but it's striking to see that this is one of the things that's happening now. So just attention to the language here. In Oregon, magic mushroom facilitators, so it's not clinicians or therapists, they're just called facilitators, receive licenses to give psilocybin, to supervise the consumption of psilocybin by customers, not by patients. So this is really offering an alternative to a medical model, which is very striking. That's what we were writing about in our book. We were saying there are ethical reasons to come up with something like this, and then a few years later, this actual model has arisen. So we'll see how that turns out. Okay, I think I'm in the last stretch here, and I just want to come back to this issue of whether a drug-influenced mental state that feels to you like love really is love, and how you would even determine that. Now here's a skeptical start. Here are some researchers who decided to test lay people's attitudes about hypothetical love drugs, and they sort of cite the Love Drugs book by Julian Savulescu and myself. And they do a proper experiment here where they randomize participants to consider one situation where somebody uses a love drug to try to rekindle feelings of closeness and intimacy for their partner, and another condition where they use psychological counseling to achieve the same end. And in either case, it's stipulated that it works. So they're just manipulating what the person uses, but everything else is described the same. And their big take-home finding here was that many people in their studies, the majority, reported that love resulting from the use of love drugs was just less authentic than love that results from psychological counseling. So people here, at least in the way the case was described, seem to have some skepticism, and I think some skepticism is warranted. But I also think it matters on precisely how the case is described. And so I just want to show you exactly the materials that they used in this study, and then I hope we'll talk about it a little bit. I want to get your impression. Here's the exact case. Paul is 30 years old and is in a relationship with Sophie for about 10 years. Regrettably, he realizes that he no longer loves Sophie as much as in the early days of their relationship. He hesitates to stay with her. Paul then goes to a doctor who recommends that he chooses one among several treatments. After having obtained Sophie's consent, Paul chooses to take a revolutionary new treatment under a pill form that could improve his romantic condition by facilitating his appreciation of Sophie's qualities. The revolutionary pill, which has been clinically tested and proven 100% reliable, intensifies the feeling of romantic love that we feel for a person. After 1 month of treatment, during which Paul had the feeling of a gradual increase of his love for Sophie, he feels again, just like in the early days, love for his partner and decides to stay with her. Okay. And then they ask people, how authentic is this love that Paul feels? How intense is this love that Paul feels? And how long-lasting is this love that Paul feels? And just to be clear, this is one of two conditions. And the other condition, instead of a revolutionary pill, it's called a revolutionary new therapy. And then it's like a psychological therapy where there are no drugs involved. So that's the comparison. So I'm really curious what you think about this case. First of all, do you agree that the love at the end sort of does seem a little inauthentic? Raise your hand if that seems like sort of plausible to you. I feel that way. There's no embarrassment here. I want to try to get your impression about why you think that is. What is it that's causing you to feel that way about this case? So just pick out some features of this case that bring you to the conclusion that, yeah, something feels a little bit off about this. I'm not so sure that whatever this love is that Paul feels for Sophie at the end is really authentic. So what contributes to your impression of that? Yeah. 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 It almost seems like a love potion or a magic pill or something. And so you have to imagine, does it work like a love elixir and it somehow just magically causes love? And then if you stop taking the pill, does then it goes away? I think it's reasonable to be a little bit concerned here because you don't know why it's working exactly. So yeah, one major point is we have to actually understand the mechanisms. You might have two people, both of whom equally report that they're in love with someone after undergoing a treatment, but one of them might work in such a way that we sort of think, yeah, I can sort of see how whatever they have really is love, and the other one might work in a different way. So that's the sort of thing that we'll come back to. Other things about this case that kind of make it seem inauthentic. Yeah.
I would like to know a little bit about the reasons or the specific aspects of his love for Sophie that he find it real.
Yeah.
I think this preliminary background information and to what was said over there. And then if those specific things were changing, or if it was just some blown up new experience.
Yeah. Yeah, imagine that Paul's love for Sophie faded because she never speaks to him anymore or something. Seems like, well, that would be a relevant thing to know. We need to understand why the feelings have come about this way to know what it would mean to sort of correct for that. So yeah, and we also don't hear much about Sophie's side of the story, It's all about Paul and Paul's feelings, but we don't get the context. Why are Paul's feelings that way, and what's the dynamic between the couple? Which is just as important as what Paul is privately feeling. Yeah. Other thoughts? Yeah. Yeah. Yeah, there's this sense of like popping a pill. It's almost a phrase that people use precisely to criticize quick fixes. You know, what are you going to do? Just pop a pill and try to solve your problems. It kind of has that feeling. Yeah. Yes, back there. Yeah, so you might think that love is something that requires effort and knowledge and input and awareness. So if something just happens to you, you know, you might just as well have a delusion or an obsession or something. Love takes work, yeah. And this doesn't seem to involve any work or effort on Paul's part, yeah. Yeah, if we know that somebody really learned something and they have a new perspective on the relationship so that they can practice different types of behaviors because they understand why that's important to do, that's the sort of thing where you have a reason to think it might be durable. You know, sometimes we really do have a lesson in life and we go, whoa, I was really approaching that the wrong way and I now know to do better. And when we can see someone's process of thought and we can see that they're sincere, that they really did have an insight, it kind of gives us reason to trust that that insight will continue to have ramifications for down the road. Any final worries? Yes?
I think everything that has been said so far really points to the importance of this kind of therapy being embedded in a psychotherapeutic context where you can actually clarify those questions. And I think it is very important to look at the biography and the history and
Yeah.
decrease. But I think it's equally important, or maybe even more important, to clarify the question, why does Paul want to take it?
Yeah.
So what are his expectations from this kind of what was his intention? I think that's a great question.
I think that's exactly right. And we wrote a little commentary on this, raising some critical points, one of which was that in all the love drugs work that Julian and I have done, we always talk about the drugs as a supplement to counseling, not as something that you take on your own, where it's either drugs or counseling. But in their study design, that's precisely the dichotomy that they drew. They said, in one case, you take a pill without counseling. In the other case, you do counseling without a pill. So they didn't even test the condition, which is the one that we described, which is pill plus counseling. Precisely because you have to engage with reasons. You have to understand the narrative history and all the kinds of comments that you all have made. So we decided to, and just a final point, which is that the pill is described as 100% reliable. So this is a further point, which is it has this deterministic quality. You take the pill and you will feel love. It's going to work every time. But it's like no actual substance has that effect. And certainly no medicine is 100% reliable. So there's also just a violation of realism here. It's almost like you're talking about a science fiction type pill that has some magical means of working. And so we're concerned that the realism might not be as it could be as well. So we decided to run a little follow-up study where we replicate their design in the love drug condition, but we have basically a more realistic version of it that involves things like what were Paul's reasons for wanting to undertake the treatment and so forth. And then we ask the same questions. How authentic is the love? How durable? How intense? And so forth. So let me just show you the way that we describe the case. So one thing I just want to say is we tried to preserve as much of their case as we could. So we say Paul and Sophie, you know, in follow-up work, we want to not have such a heteronormative, you know, male-female couple. There's all sorts of things you can vary about these cases. But for now, we were just trying to follow on from their example. So here we say Paul and Sophie are 30 years old and have been in a relationship with each other for about 10 years. They are married. So we're not talking about Paul and he. We're talking about this is something they're doing together. A relationship involves two people. They're married, they have 2 young children. Regrettably, they realize that they no longer love each other as much as in the early days of their relationship. They hesitate to stay in the relationship with each other, and they've even considered getting a divorce, but still they think there are reasons to try to make it work. There are the kids to think about, so now we're bringing in welfare considerations of other parties. That's certainly a reason to try to improve a relationship. They don't hate each other, so this is not like an abusive, toxic relationship. It's just sort of an unhappy one. Their values are basically in line. They have a lot in common, shared routines, shared finances, shared history. Their lives, their memories, and even their identities are intertwined. So this biographical narrative thing that you were talking about. You know, if only they could find a way to bring back a feeling of love and connection within the relationship, but nothing has worked so far. So a further point here is they've tried out everything else. So now it's also like, this is kind of a last attempt. They're not just wantonly taking drugs to try to fix the problem. They don't want a quick fix. They've actually done all the non-quick options and exhausted those options. Okay, one day they read about a new study going on at a prestigious university in their town. The researchers are recruiting long-term romantic partners for a study on pharmacologically assisted psychotherapy for couples. Now we phrase it this way because this is a real thing that's happening now. So I told you about that study earlier, right? Where you had MDMA-assisted counseling for couples where one of them had PTSD. So this is a real-life example. According to the recruitment materials, the study involves taking a low-risk, non-addictive pill as a supplement to couples counseling. So we are explicit about that. Like any intervention, this pill is not 100% effective. So it is not a magical pill. It doesn't guarantee a successful result. Instead, it temporarily fosters greater feelings of empathy and connectedness between partners and enables people to talk more openly and honestly about their emotions and difficulties. So now you have a sense of the mechanism. You know, partly why you're having a problem with the relationship is because you haven't been able to talk honestly about how you feel, but now you have a drug that helps you do that. You can sort of connect the dots, and you see how that might, you know, count as an improvement. However, once the immediate effects of the pill wear off, usually after a few hours, the couple still has a lot of work to do to apply whatever they've learned from the experience to their daily lives. It's kind of amazing how you have all raised exactly the points that we were then going to do. It's kind of this nice one-to-one mapping. So yeah, the learning issue. Once the drug wears off, you still have to take ownership of the relationship and, you know, practice better behaviors. So Paul and Sophie decide to enroll in the study. The study lasts for 1 month, during which the couple undergoes 2 separate pill-enhanced therapy sessions. So it's not like you're taking it every day. This is something that happens on one occasion and then another occasion. As they work through their problems and learn to see each other again with fresh eyes, Paul and Sophie feel a gradual increase in their love, and they decide to stay together. So it ends the same way. So the first thing I just want to show you is we asked participants, how realistic do you think this case is? And so these are the measurements of realism here. Now, I have to explain there's 3 things here, and I only told you about 2 conditions, so let me explain what the third one is. On the left-hand side is their exact case that they use. We just use the exact same material and ask the exact same question. So this is a replication of their love pill condition. This other one, which we call Lantian realistic, so the first author's name is Lantian, is a minimal change. All we did was say that the pill is not 100% effective, but we kept everything else the same. And our point was, in all of our actual love drugs work, we're adamant that we are not talking about a love potion. We're talking about actual chemicals that affect the brain and work in a statistical way, interacting with a whole bunch of other factors. So for it to even count as a love drug, minimally on our conception, it cannot be the case that the drug is 100% effective and magically works to cause love. So in this case, you see that people don't actually think that's any more realistic, you know, that somebody just takes a pill and it's one-sided and so forth. But we felt it was important to at least test that condition to see what are the minimal criteria. And then this is the case I just read to you, which we call the ideal case. So just to be clear, this is not a very carefully matched case. We changed a whole lot of things. I mean, we changed like a dozen things from their case. So in future studies, we're going to have to change one thing at a time and find out, is it the fact that they had children? Is that what changes people's attitudes? Is it the fact that they, you know, worked through their problems because they were more emotionally engaged? So we don't actually know which feature of our case is driving these results. We just kind of did a kitchen sink. We threw in all these ingredients that we thought would probably make the thing seem more realistic, more authentic, and more realistic. So here you see, you know, these much higher ratings of realism. Now here are the maybe more interesting results. So those are the authenticity ratings on the left. So again, on the left-hand side, you have their original case. The midpoint is 4, and so their score is like 2.5, which means people really think that it is inauthentic. Not just that it's somehow less authentic, but that this is not a very authentic love. When you just say that the drug is not 100% effective, you actually increase authenticity ratings quite a bit. So that was quite striking. Just the mere fact that it's not deterministic bumps up authenticity ratings. And then in our ideal case, you see people think it's actually more authentic than not. So it crosses over the midpoint of the line. Pretty interesting. Here are ratings for durability. So people also think it's going to last longer in our case. Why? Because, yeah, you actually learned a lesson that you're implementing. You have a reason to think that this is going to last, and it's not like you stop taking the pill and then the love immediately fades. And then in the final one is just ratings of intensity. And interestingly here, people didn't think that the love is any more intense in our ideal case compared to their original case. You might actually think maybe it's even more intense if it's a magical love potion. I mean, intensity probably follows from that, but it doesn't mean that it's going to be long-lasting. So we didn't find that ours was any more intense. So that's really it. I mean, I've been going on for 50 minutes, so let me end there. Thanks for your time and attention, and let's open up for questions.